So, welcome everyone to the CEG Tower Hamlets LEV update for 2025-2026. My name is Toyin Omisori, and I'm the primary care facilitator for Tower Hamlets. And presenting with me today is Joe Tizia, the senior primary care facilitator for Tower Hamlets and Waltham Forest. So I'd just like to give you a quick outline of who we are, just in case you don't know who we are. So we're CEG, the Clinical Effectiveness Group, and we are a not-for-profit organisation based at Queen Mary University of London. We've been working with practices in North East London for over 30 years and helping practices by supporting quality improvement. And some of the ways we do this is by building searches, templates, software tools, dashboards, etc. And we're a team that's made up of GPs, clinical leads, data analysts, and primary care facilitators. Now, for the 7 boroughs that we cover in North East London, there is a dedicated primary care facilitator for each one. Now, these are the LES contracts that I'll be going through with you today in the presentation. And as you can see, most of the contracts, there's been no changes this year, so everything's just rolled over. But there are changes for the integrated care contract and the ICCQ enablers. So starting off with integrated care, wider determinants of health. So this is for your LTC and complex care patients, and it involves asking patients about their communication preferences, their health literacy, their housing and income vulnerability, and social isolation. So the payment code is the same. It's quality of life assessment completed, but you can now complete this every 24 months instead of every 12 months. So this is now gone from an annual metric to one that you can do every 2 years. The payment code, as usual, is at the top of the wider determinants page in the LTC template and in most of the other templates that you commonly use. Integrated care asthma only for adults and children. So the payment code has changed for this year. So last year it was personal care plan completed, but now the new payment code is health education, structured patient focused asthma discussion. And this payment code has been updated in the LTC template and also the pediatric asthma and allergy template. And as you know, for adult asthma only, you also have to do a wider determinant of health. But as I just mentioned, you can complete this now every 24 months instead of every 12 months. Okay, so moving on to integrated care diabetes, there are 2 new metrics for this domain, and that is the type 2 8 care processes and the type 2 diabetes combined triple target. So for the 8 care processes, you need to make sure that you're recording the BMI, the blood pressure, the cholesterol, HbA1c, creatinine, blood tests, the annual urine ACR. You need to do a foot check examination and record the patient's smoking status. For the diabetes triple target, you need to ensure that the blood pressure is less than or equal to 140/90. The HbA1c result is less than or equal to 58. And if the patient is in the primary or secondary prevention, you need to ensure that you're prescribing them a statin. Now, the BP, HbA1c, and the annual urine ACR have been removed as individual metrics in the integrated care contract because, as you can see, they are already included in the two new metrics. Now, I just want to go into a little bit more detail for the type 2 diabetes triple target. So a patient needs to fit into one of the three categories. So primary prevention, secondary prevention, or no prevention. So for primary prevention cohort, these are patients who are aged between 25 to 80 years, and they are not on the CHD or stroke TIA register. And if they have a Q risk of 10 or more percent, then you need to prescribe them a statin. For the secondary prevention cohort, this means that they are on a CHD or the stroke TIA register, and they also need to be prescribed a statin. For the no prevention cohort, they don't need to be prescribed statin. But for the three cohorts, you also need to ensure that their BP is less than or equal to 140/90, and their HbA1c is less than or equal to 58. Now I'm going to move on to the integrated care statin metrics. There's two metrics for this. So there's the primary prevention statins and the secondary prevention statins. But this is not to be confused with the diabetes triple target. So these are two different metrics. So for the primary prevention statins, these are patients who do not have CVD, but they either are on the hypertension register and have a Q risk of more than or equal to 20%, or they're on the CKD or diabetes register with a Q risk of more than or equal to 10%. And they need to be prescribed a statin in the last 12 months. It could be any statin, although the preferred first line option is that you prescribe them atorvastatin 20 milligrams. For the secondary prevention statins, these are patients who do have CVD. So they're either on the CHD, stroke, TIA, PAD, or AF register. And they also need to be prescribed statin within the last 12 months, but it should be a statin at a higher dose. So this could be atorvastatin 40 milligrams or 80 milligram dose. Now, what's different this year is that you can prescribe an alternative lipid-lowering medication, such as ezetimibe, if statin, for whatever reason, is unsuitable. But if you do prescribe lipid-lowering therapy, then you must make sure that you're coding a statin exception code. So this could be statin not indicated, contraindicated, or not tolerated within the financial year, or if the patient has a statin adverse reaction or statin allergy coded in their record ever. There's also changes for the integrated care antipsychotic monitoring, which is for patients who are on antipsychotic drugs. So the elements that you need to include for the monitoring has been shortened this year. So you need to make sure that you code antipsychotic medication physical health check code or the antipsychotic medication code. Also, blood pressure, BMI, and the annual bloods for HbA1c and HDL cholesterol. So what has been removed for this year, but that was included last year, is the waist circumference measurement, the pulse rate or rhythm, and the blood for ALT, full blood count, and UNEs. So these things are not required for the monitoring for this year, but they were last year. There has also been some target changes for two of the metrics in integrated care. So for the number of care planning completed in the last 12 months, so this is for your Part B, the target has been lowered from 80% to 70 to 75%. So this means that 50% of the payment will be given if you achieve 70%, and a further 50% payment, which would be the maximum payment, you'll achieve for hitting the 75% mark. For the CKD, blood pressure less than 140/90 metric, the target has been raised from 60% to 65%. So there are integrated care support searches that you can use to help you achieve your targets, and they can be found in the Tower Hamlet practice support folder, which you can access via the CEG domain. There are several searches in the folder. So you've got some support searches for antipsychotic monitoring, asthma plans and reviews. There's also a suite of searches for blood pressure, which identifies patients whose blood pressures are out of target or who've not had a blood pressure recorded within the financial year. There's also support searches for the two new diabetes metrics. Are there any questions? Okay, so if there's no further questions, I'm going to move on to the ICCQ enablers. So for the digitally excluded enabler, everything's more or less the same as it was last year. So what you need to do is contact patients with no mobile phone number recorded, but they should be new and different patients to the ones that you have contacted in previous years. The payment code is the same, education about access to patient-facing service, and you need to record this if you speak with a patient and successfully update their mobile phone number, or equally, if the patient doesn't have a mobile phone number or does not wish to disclose it, you should also use this payment code to show that you've done the work. You also need to make sure that you have reviewed and updated your digital exclusion policy by the 1st of August. So that deadline is coming up soon. And there is a new component to this enabler, and it's at PCN level. So your PCN needs to set up in-person learning sessions, and it should be at least one per quarter, to support patients on how to access and use GP services digitally. The CYP Access Enabler this year has two components. So the young people turning 14 years is one that you already know about, and there's not a lot of changes to it, but I'll just run through it quickly. So you need to proactively update contact details for your 14-year-old patients. You need to send letters and leaflets to patients turning 14 years old, and the letter explains to them how they can access healthcare services at their GP. It also lets them know that they are able to see a clinician on their own if they wish, and that they have a right to confidentiality. The payment code for this is patient in local audit, and this code is attached to the letter, which you can find in EMIS. So that's called Young People Turning 14 Years. And once you save that onto the patient's record, the payment code will also be saved. And for this enabler, you also have to ensure that the young people's confidentiality policy is in place. you need to make sure that your waiting areas and website have outlined young people specific services like CAMS or C-Card. You need to show evidence on your website that you have outlined young people's basic rights in healthcare. Staff training should also be provided around young people's rights, and you should show evidence that you are listening to your young people, and this can be via feedback or comments from the PPG or maybe school or a youth club, etc. So there is a new component to the CYP Access Enabler, and that is for reasonable adjustments for under 25-year-olds. So what this requires is that you record the reasonable adjustment flag for eligible patients who are under 25. So eligible patients include patients who have autism, ADHD, learning disabilities or Down syndrome, mental health, sensory impairment, etc. So the coding for reasonable adjustment flag has now changed. It used to be 2 codes that you needed to enter onto the record for the flag, but now it's just this 1 code, which is impairment with substantial and long-term adverse effects on normal day-to-day activity. So the coding, or all the codings that you need for reasonable adjustments, can be found in our reasonable adjustment template and also our reasonable adjustment page, which should be on most of the templates that you use, including the LTC review template. However, if after discussion with the patient does not want or need an adjustment, you can code discussion about options. Now you can find this code on the LTC review template on the main page, but please note that this section will not appear unless the patient that you have on your system is actually under 25 years of age. Once again, there are support searches for your enablers, and they can be found in the Tower Hamlets practice support folder, and you can copy them over from the CEG domain. I also just want to quickly mention the APL renal tool enabler. So this is the same as last year, so you will have to complete the 4 indicators listed. So the first one, falling EGFR trigger, which should be reviewed and actioned monthly. The other 3 indicators need to be reviewed and actioned every 3 months as a minimum. And for those of you who are not familiar with the CEG APL renal tool, it is a tool to help practices manage their CKD patients or patients with an indication of CKD, and it does this by highlighting critical falls in renal function. So the first link on the page takes you to our dedicated APL renal tool website page, where you can find out more information about the tool. There's also a webinar recording that shows you how to use the tool. And the second link takes you to the online request form. So if you've not already downloaded the tool, if you fill out this form, you'll receive an email where you can download the tool. Are there any questions?
Oh, Twin, there were a couple. I was just about to reply to one, but from Carol, and Carol says from Chris Street that the reasonable adjustment page is not in the LD template, but it is in the LTC review. It's a library item, isn't it? So there is the page in there. So So although the information that you need to put on might not be on the learning disabilities page, you have a page on that template to enter reasonable adjustment information. Yeah. Okay. And the other one, digitally excluded. Some patients do not give us mobile numbers, but email addresses. Now, I don't think these are digitally excluded. However, if we follow the spec to the letter, we have to write to them as they are digitally excluded as they have no mobile number.
Yes. So the contract, it seems to be specifically about mobile numbers. So yes, you are going to have to treat it that way. Either way, do make sure you enter the payment code, the education about patient-facing service code, and document everything that you discuss with the patient about their contact details. Was that the only two?
Yeah.
Okay.
Yeah.
Okay. Okay, so I'm going to move on. Okay, so moving on to NHS health checks. So once again, there's been no changes for this year, but I did want to highlight what a full NHS health check review should include, and also what the payment metrics are. So the payment metrics are that you need to complete an NHS health check within the last 15 months. You need to record the pulse rhythm for patients who are 65 years and over. For eligible patients, you need to discuss or offer lifestyle programs. So this could be a referral to a weight management service or a referral to the National Diabetes Prevention Program, or even for smoking cessation. You also need to record the carer status, and for patients who are in the high risk of CVD cohort, you need to do an annual review, and you need to prescribe statin for these patients. Now, for a full NHS health check review, you need to make sure that you've recorded the ethnicity, the blood pressure, BMI, smoking status. You need to record the alcohol use score. So this is audit C or audit, the physical activity of the patient, and their family history of CHD. You need to do calculation for the Q risk and the Q diabetes score, and do a total or HDL cholesterol blood test. And you need to make sure that you're discussing dementia awareness for patients who are 65 years and over. So the NHS health check page in the health check template has recently been updated to include all of these relevant sections in one page to make it easier to record this information during consultations. There is also a NHS health check support searches, but I just want to bring to your attention that in this folder, there is a quality folder that has a suite of searches that help you identify any missing elements of a full NHS health check. So this can help you improve the quality of annual reviews that you have done. Okay, so moving on to the anticoagulation LES, which is for primary care-based services. This is for AF patients initiated on anticoagulant or DOACs, or if they're monitored on DOACs in primary care only. So you'll get payment for initiation if you code Phenin General Practitioner Anticoagulation Clinic, and also if you code new medication commence. For monitoring, you get payment if you have coded anticoagulation monitoring in primary care, and you've coded either DOAC dose changed or the code change of medication, or DOAC dose unchanged. And then you also have to do the monitoring, which is the creatinine blood test, the estimated creatinine clearance, and the weight measurement. And these need to be done once in 12 months. So you can find all the codes for this in the LTC review template on the AF/DOAC/FitK antagonist page. And then I just want to quickly run through the rest of your LES contracts. So as I said before, there's been no changes, but I'm just going to give you a quick recap. So for latent TB, this is for eligible patients. So they need to be between the ages of 16 and 35, being born in a high-risk TB country, and lived in the UK for less than 5 years. So you need to do an IGRA blood test for them. But when the results come back to get payment, you must make sure that you are coding whether it is negative or positive. And then you get further payment if the result is positive and you have referred them to the TB clinic. For sexual health and LARC, the sexual health component, you get payment for doing STI screening for your patients who are aged between 15 and 59 years. There's further payment if there is a positive chlamydia result and the patient is aged between 15 and 24 years. For STI diagnosis, so this is positive results, you need to discuss and record partner notification. If it's a positive chlamydia result, you also need to code that you followed up with the patient. For other STI diagnosis, you need to make sure that you are referring the patients to the appropriate clinic. For the LARC component, you get payment for coil and implant fittings and removals, and you do also get payment if you have a failed attempt at fitting coils or implants or the removal of them. For practices who do inter-practice referrals, there is payment. And for any DNA'd appointments for these inter-practice referrals, there is also payment. For substance misuse, for eligible patients, you need to make sure you've done a health check and health plan. There is also payment for doing an audit fee, and if the score is 5 or above, doing the full audit. You need to make sure that you're recording an audit fee if none has been done in the last 3 years, but this does exclude newly registered patients. You need to discuss and code brief alcohol advice for audit scores 8 and above. And you need to refer to the reset treatment service if the audit score is 20 or above. You get payment for annual ECGs for patients who have been prescribed methadone and antipsychotic medication. And there is payment for the monitoring and prescribing of opiate substitute drug therapy. For your surgical aftercare and wound care, this has 2 components. So for surgical aftercare, this is for patients with wound care after secondary care interventions. So maybe they've had an operation at the hospital. You need to code post-operative wound care or removal sutures or clips to get payment. For the minor injury component, this is for your patients who need a wound care without secondary care intervention. So this could be things like grazes, cuts, minor burns. If you treat them and you code consultation for minor injury, you also get payment. So that's just a quick recap of your LEV contract. Is there any questions?
Oh, Toyin, there's one about, I think when you were doing the NHS health check bit,
Right.
and it's from Jubilee Practice, from Claire. For patients with pre-diabetes, do they have an annual HbA1c and then 5-year NHS health check? What does the spec say about them? Do you know? So it's almost like your high-risk diabetic patients, isn't it?
Yeah. I'm not sure what the spec says. It does seem to make sense to me that if you have a high-risk diabetic patient, that it would be a good idea to do an annual HbA1c blood test. That's something that I will have to check to see if the spec says anything about. So I will have to find that out and get back to you, Claire.
That was it. Yeah, and they've said thanks very much. And then somebody said it's very clear. Can you share it with the care group so the presentation goes into the primary care bulletin? Maybe the link when we put the stuff up.
Yep, so the recording and slides will be made available to practices, and we will let you know when it's ready via our CGE bulletin. So, yep. Any further questions? Nope. Okay, so I'm going to hand over to Jo so she can quickly go through the CEG resources.
Okay, thanks very much, Toyin. As the other Josephine said, you've done a very lovely and clear presentation, so thanks very much. I'm just going to have a few minutes, not much longer really, just reminding you and illustrating some of the resources that we offer at CEG, just to so that if you want to use any of them or are unaware, hopefully this will help you know what we've got, and also hopefully you'll contact us so that we can come and assist where required. So we have what are called our APL tools. The APL stands for Active Patient Link Tools, and we've got a few of those. We've got one, the Childhood IMS, which has been out a little time now actually, and the purpose of this tool is that it allows practices to view children with incomplete or overdue sets of childhood immunizations to help in better call and recall. The cancer diagnosis audit tool is to review practices, processes around suspected cancer referrals leading to confirmed diagnosis. We have APL NDPP tool, which is the National Diabetes Prevention Programme tool, and this enables you to view a list of eligible patients for referral to the NDPP programme who are at risk of diabetes. And finally, the AF tool, atrial fibrillation tool, and the purpose of this tool is to help clinicians review AF patients to ensure they're on the safest and most effective medications. If you haven't seen these tools, how they work is you get a set of searches which you can run on your clinical EMIS system, and then the results from the set of searches then go into an Excel-based tool which sits outside of the clinical system, but it uses the data from your clinical system, and then it'll show you a number of ways of looking at these patients to identify who you may need to bring in for recall. So if you're not familiar with these and want a session, please contact Toyin and we can do that. Okay, next slide, please, Toyin, or can I do it? Can you do the next slide?
Yep.
Okay, thank you. Okay, so the CEG resources, of course, what we also do, and I'm sure you're all very familiar with this, are the support searches in the population reporting of EMIS. So they're split. You go on to the clinical effectiveness group Tower Hamlets domain, and you will see Tower Hamlets practice support for 2025 to 26, and you'll see a number of folders under there. So for example, in the folder number 1, these are the ICB contract searches. In there, you will find your ADHD adult reviews, the enabler support, searches, the integrated care support, the substance misuse, NIS support, and the wider determinant support. So under each folder, there'll be a number of subfolders, and in those subfolders, you'll be able to see searches that will demonstrate to you how you are progressing on these contracts, and there'll also be some support and recall searches in there to help identify patients who maybe haven't had the indicator done or patients for recall. The next folder is your public health suite of searches, and in there TB, NHS Health Check, sexual health and LARC support searches. You've got your PCN contract folder at the moment in there. You've got the IIF suite of searches, the Investment and Impact Fund. You've got the DES SMI Physical Health Check suite of searches, and the Care Home Supplementary Service. So again, have a look at those, get familiar with them, and then you'll be able to see how you're progressing on those contracts. And then in the other folders, there's, sorry, Toyin, a few more, but just navigate your way. For example, in the immunisations and vaccinations, you'll find your COVID searches as well. Okay, thanks, Toyin. Next slide. Okay, the other area or way that we support you is that we produce a suite of our CEG clinical templates. Some of these are, you can see here, we've got one, the biggest one really is the LTC review, and that's a smart template, and pages will be shown for you depending on what diagnosis the patient has. So if you have somebody who's got diabetes and COPD, you'll see a page so you can do your diabetic and COPD reviews. If somebody else also has learning disabilities, then the learning disabilities page will also show up. And then the other some of the other templates we have, sexual health, and all these templates will have the codes that are required for both QOF and for your enhanced services, substance misuse, women's health. You can search for them by looking at RP at the beginning of the name of the template. We would also urge you to make sure that you do read our e-bulletin, because if there is a change to the template, we will inform you of the change to the template. It will have a new version number, and you would need to actually use this template with the new version number. What practices sometimes can get a little bit stuck over is if you have it in your favorites, the favorites will hold on to the old version number. So we would urge you to either search for the new version, or is there the F12 key into our Hamlets toy? And yes, there isn't, yeah, isn't there? So the F12 key is the where you can launch from the F12 key a picking list from which you'll be able to choose any of our templates, and those templates will always be the most up to date. So again, if you're listening to me and think, I don't really know what she's talking about with this F12 key, please contact Toyin, who'll be able to send you some instructions on how to set this up. It's a very useful resource. Next slide, please. Okay, and this is just a screenshot here that we've put up of our CEG website. So the example that Toyin has shown here are the resources that you can look at. We have, as I said, the software tools, the APL tools, so you can get a little bit more information about those, and there'll be some instructions on how to use them. But you can contact us actually if you need further information about those. Webinars, all our recent webinars we host on our website, so you'll be able to see this one up there. GP contract guidance, we often do fact files outlining requirements of any of the major GP contracts. They'll be there. There's some handy how-to videos for the clinical systems if you're using EMIS and System 1. Searches, templates, dashboards, and there's the cancer toolkit. So really it's just to give you a quick example of what our website looks like, and just to flag it up so that you can use it at your leisure, but become familiar with what's up there. Next slide, please. And of course, importantly, our practice visits and our one-to-one support, which can be in person or virtual. So we offer all practices across now, not just Tower Hamlets, but across now, we offer every practice practice visit. The purpose of this practice visit can be to go through the contracts with your clinicians and your staff. It can also be if you've got new staff and they need some familiarization with some of our tools, we're very happy to come and demonstrate. Can be that your nursing staff maybe might need some help with, for example, the templates. Again, we're very happy to do visits, whether it's online or in person, to support you with that. I would urge you, when you get the email from Toyin saying we're just about to start our practice visits, I would definitely urge you to take this up, because you'll have Toyin coming in with her vast amount of knowledge about all the searches and the templates and the contracts, and she's very happy to come out and make sure that you are using the most up-to-date versions of things, and also that you understand the searches and how they're all set up. They can sometimes get a bit complex, so we would urge you to take up that visit. Next slide, please, Toyin. And again, Toyin's mentioned this a few times in the presentation, that the way we communicate with practices on a weekly basis is via the practice CEG or e-bulletin. If this doesn't look familiar to you, please again get in contact with us to make sure that you have subscribed to this very useful weekly e-bulletin. In here, we will put lots of information, including, as I said earlier, whether there's been update searches, update templates, whether there's future webinars, and we also include guidance if there's new contracts or new things coming out. So please make sure you receive this, because otherwise it means that you could miss out on very important information. Toyin, is that on the the CG e-bulletin with the line underneath? Is that where they can sign up?
Yeah, that's the link to the online sign-up form. But Great. You can also email me as well to put you on the mailing list if that's easier.
Great, thanks, Toyin. And next slide, please. Okay, this is just, I think this is the last slide, isn't it, Toyin? So this is just our web links there. So you've got them handy for you. So if you click on the first one, you'd get to our resources page. If you click on the second one, you'll get to the APL software tools page. And if you clicked on the third one, that's where you will find all the dashboards that we produce, that you'll be able to find out how you are doing, or actually how the whole of Tower Hamlets are doing for their contracts. The little I forgot what that is, QR code, isn't it? On the, that's the one. On the right hand side there, if you take a picture of that, that will take you directly to our website. So everything's there for you to be able to easily access. Next slide. And yeah, just the CG contacts for Tower Hamlets and Toyin and myself. First instance, I'd probably always say go to Toyin. She'll be able to get in contact with you, I'm sure, much faster than I will. So I would suggest going to Toyin. But I am also here to help if you have any other questions as well. And is that the last one? Yes. Yeah. Thank you, everybody, for coming. And please, if you've got any questions now, let us know.